The Hammersmith Neonatal Neurological Examination, or HNNE, consists of 34 different items, each of which can be scored as optimal or suboptimal for term-born infants, giving a total optimality score of 34. This term optimality, used for term-born infants, should not be applied to preterm infants, for whom there are reference values for the range of findings at term age that are detailed later. In newborn full-term infants, we talk of optimality scores based on findings in a large cohort of term infants who were found to be developmentally normal at 12 to 18 months. The maturation of the preterm brain is different compared to term infants, even if their scans do not show abnormality and their outcomes are in the normal range. Their experiences are different, for example, lying on a bed rather than being increasingly flexed in utero, being exposed to light, being tube-fed, etc. These experiences affect the exam, and at term age, some item responses are different from newborn term infants. Instead of using the expression optimality for preterm infants, we give a range of normative reference values derived from a large preterm population with normal or near normal cranial ultrasound scans and normal 2-year neurodevelopmental outcomes. These values clearly overlap with the findings for term infants, but for many, the range of findings is wider and less defined. If you are using the Hammersmith Neonatal Neurological Exam for daily clinical purposes, you can score it using the normal ranges for newborn term infants and preterms of different gestational ages at term equivalent age, shown on the pro forma from the paper by Ricci et al., with the small boxes to the right of the page. This paper is an extension of the original paper on preterm infants at term age by Makuri et al. From 2003. These small boxes in columns reflect the columns of the recording sheet. There is a number above each column, corresponding to the numbers above the columns in the main part of the form. The 0.5 columns are used when findings fall between two columns. When the Hammersmith neonatal exam was first standardized in 224 normal term infants, the single most common response for any one item is shown in the box with the thick black surround, and the distribution of responses within the 90th centile around that were determined. The numbers within the boxes are the percentages of infants showing these particular responses from the standardization studies. Findings occurring in more than 10% of the population were considered optimal. Boxes with small numbers of infants that fell between boxes with larger numbers, greater than 10%, were also considered optimal, defining a range of optimality. Later, the same procedure was undertaken for preterm infants at term age. The first paper from 2003 examined 157 preterm infants born between 25 and 34 weeks gestation, giving the median column finding, and the range of responses was recorded for 3 gestational age groups. A later paper enrolled 380 infants from 5 centres. They all had normal or minor ultrasound findings and were thought normal at 2 years. This larger cohort was divided into 4 preterm gestational age groups. Again, the commonest response and the range of responses were recorded. Noticeably, in the preterms at term age, the range of responses was much larger than in term infants, especially for tone items, where additionally the median value was usually different. So on this form, the grey boxes denote optimal responses from term infants, or the expected range in preterm infants, scoring 1, whilst the responses in white boxes are considered suboptimal and score 0. Using this simple scoring system, the possible score for any one item is 0 or 1. Here are some examples. If a newborn full-term infant has a response in column 4 for this posture item, then you can see from the number in the equivalent grey box that 90% of term infants scored similarly. This response is optimal and scores 1. If the infant had scored in column 3, you can see that only 6% of such infants had this score. The box is white, thus suboptimal, and the score is 0. If for the same posture item a 29-week infant at term age has a response of 2.5, this now lies just within the expected range and the score is 1. If the infant had a response in column 4, this would also be in the expected range, though at the upper end, and the score is also 1. For this and many other tone items, most infants born preterm score in column 3 at term age, 1 column less than that for newborn term infants. For other items, for example in the tone pattern, reflex and behavioural sections, the median scores are similar. Scoring the tone pattern section. For the first item in the tone pattern section, compare responses to arm and leg traction. For the second item, note posture in supine. For the third item, compare response to leg traction and the measure of the popliteal angle. For the fourth item, compare the findings for neck extensor and flexor tone when the infant is held in a sitting position. And for the fifth item, compare the findings for neck extensor and flexor tone when the infant is 1. Pulled up towards sitting and 2. Held in ventral suspension. As an example, for the first item comparing arm and leg traction responses, the findings should either be in the same column as shown here, or arm traction response is 1 column less than the leg traction response as shown here, but not with the arm traction response being 2 columns greater than the leg traction response as shown here. The optimal and most common scores for this item are in column 3, except for infants born very preterm at 25 to 27 weeks, when the most common score was in column 2. If you are using the Hammersmith neonatal neurological exam in a study or for research, it is necessary to read the published papers for further details on the scoring and on its use in different cohorts where normal ranges have been derived. Normal ranges can be different for term and preterm cohorts, the age at examination, and infants of different ethnic backgrounds.